Welcome! In this lecture, I will describe two more viral diseases of the skin, along with a fungal one. The first is rubella. Rubella is a positive-sense, single-stranded, enveloped RNA virus. It is the etiologic or causal agent for German measles. Of course, the name doesn't mean that it's confined to only Germany. The transmission and symptoms of the disease are similar to that of measles, but often even milder. A majority of those infected don't even know they have the disease. The problem with German measles is that it's a serious threat to unvaccinated pregnant women. Congenital rubella syndrome is the result of a baby becoming infected in the womb. The risk is especially high if a woman becomes infected with the German measles virus during her first trimester. There is a 90% likelihood that she will transmit the virus to her unborn baby, and approximately 1 in 3 of those infected babies will suffer severe or fatal consequences. Babies with congenital rubella syndrome are often mentally retarded, blind, deaf, and have major cardiac abnormalities. They often are born with a distinctive blueberry rash at birth. 15%, though, of these babies, sadly, are stillborn. Because of the risk of congenital rubella syndrome, it is advisable to screen would-be mothers for their antibody titer to rubella before getting pregnant. In fact, the rubella antibody test used to be a requirement for women before getting a marriage license in most states. The good news is that the MMR, live attenuated vaccine, is protective in most cases. Worldwide, the disease still exists, and approximately 100,000 babies are born with congenital rubella syndrome every year. As recently as 2013, Japan suffered a widespread outbreak in which 8,500 young men came down with symptomatic rubella disease. 10 babies were born with congenital rubella syndrome in Japan during this outbreak. Before the outbreak, Japan only vaccinated female babies against the rubella virus. They have since reevaluated their vaccination policy. This slide illustrates just how successful universal immunization programs have been in the United States. For each of the diseases, the approximate number of cases that used to occur every year before immunizations were initiated is listed, as well as the percentage decrease after vaccination programs began. The smallpox virus is the only one that has been truly eradicated, and people no longer need to be vaccinated. The other disease agents are all still circulating, and sporadic outbreaks occur every year worldwide. It's important to keep immunizing all members of society in order to prevent a return to the pre-vaccine era. As future healthcare workers, you have a responsibility to protect not only yourself and your family, but your patients as well. The next viral infection I will describe is so-called oral herpes. The herpes simplex virus 1, or HSV1, is a member of a family of over 20 known viruses. All of them are double-stranded, enveloped DNA viruses. The outstanding feature of the family is its lifetime latency. The virus is transmitted through respiratory secretions, usually from close contact with family members. Most primary infections occur in infancy. The primary infection may go undetected or present as cold sores or fever blisters. usually externally around the mouth. Once the primary lesion heals, the virus retreats to neurons in cranial nerve 5, or the trigeminal nerve. There, the virus may be kept in check by the host's immune system, or in some individuals, reactivate whenever that person's immune system is compromised. The immune compromise may be relatively minor for some people and include emotional stress, ultraviolet light, or simple hormonal fluctuations. Although lesions usually occur around the mouth, the trigeminal nerve also serves the eye and the chin, so blisters may occur there as well. It's important to note that HSV-1's nickname oral herpes comes from the fact that most people are infected with the virus around the mouth as babies. HSV-2 is known as genital herpes because most people are infected in the genital region after sexual contact. However, it is possible to get HSV-2 in the oral cavity and HSV-1 in the genital mucosa as well. As for treatment, acyclovir may be useful in shortening the length of outbreaks, but does not cure the infection. The final types of infection I'll describe are fungal infections of the skin. These infections are described as cutaneous skin mycoses, fungi. The most common etiologic agents of these infections are all members of the fungal genera Trichophyton, Microsporium, and Epidermophyton. These organisms are often described as dermatophytes, which means they are plant-like forms growing on the skin. They are mostly harmless saprophytes, which get their energy from consuming the dead keratinized cells in the stratum corneum of the epidermis. The infections rarely spread to other systems of the body. Most of the symptoms of the infection are due to type 4 hypersensitivities and the resulting inflammatory process. Essentially, the immune system recognizes the foreign colonization and spews inflammatory cytokines in an attempt to rid the skin of the fungi. The organisms themselves are not really virulent. Susceptibility to fungal infections is at least partly genetic. These 3 fungal genera cause what are commonly called the tinnias or ringworm diseases. The name ringworm is a misnomer because these are really fungal diseases, not worm ones. The name comes from ancient times when the spreading circular rashes were thought to be caused by worms. Ringworm infections are most common on parts of the skin which are especially wet, salty, like from sweat, or oily from sebaceous glands around hair follicles. Tinea capitis refers to ringworm of the scalp. Tinea pedis refers to athlete's foot. Or ringworm of the feet, especially between the toes. Tinea cruris is ringworm of the groin area, especially around the scrotal sac. And Tinea barbae is ringworm of the face, especially in bearded areas. Fungal infections of the skin can be treated with over-the-counter medications, which include miconazole, clotrimazole, fluconazole, etc. For more stubborn infections, prescriptions for oral griseofulvin or terbinafine may be required. Unfortunately, these infections tend to reoccur, and the treatment may take many months to be effective. This concludes Skin, Part 3.